We will next go to item number 4, SB 260, Senator Monning.
Good afternoon, Mr. Chair and members. I'm prepared to present SB 260, and I'd like to introduce this by first acknowledging the many positive contributions that county organized health systems have made for our Medi-Cal system. My district includes 2 COES plans, the Central California Alliance for Health and CenCal, which covers the southern part of my district in San Luis Obispo County and part south, both of which I can personally attest to having provided excellent health care services, and they're well respected in our communities. This bill does not seek to cast aspersions on these plans or cast them as villains. Instead, it acknowledges when adequate protections and oversight can benefit consumers and possibly lead to better outcomes for patients. I accept the committee amendments that delay implementation to give county organized health system plans enough time to obtain the licensure that we think they should have. As amended, Senate Bill 260 requires that all COES plans be licensed by the Department of Managed Healthcare under the Knox-Keene Act to ensure that all Medi-Cal plans are under a single standard of regulation and that those Medi-Cal beneficiaries are afforded with all of the same consumer protections that come with licensure. The bill will give plans that only need to complete a material modification until 2017 to obtain Knox-Keene licensure, and an extra 6 months will be given to those plans that need to file an initial licensure application, or a total of 18 months. What we are seeking with SB 260 is the ability for a patient to get very clear consumer assistance services like the Independent Medical Review, or IMR, the HMO helpline, and external review. With licensure, we are also seeking the ability for DMHC to properly track and trend complaints, audit with enforceable corrective actions, and become a more consumer-focused regulator that ensures compliance with California law like timely access and network adequacy. COES plans have about 2 million Medi-Cal lives and are the recipient of state funds to administer managed care exclusively for that population, and as such, we should make sure that these taxpayer funds are being used wisely. The opponents have raised concerns about the timing of the bill, but that we know that the departments have been talking to the plans about possible Knox-Keene licensure since last fall, that the sponsor has been talking to the plans since January, and that we've had several meetings and are willing to continue that dialogue over the next couple of months. The time has come for COES plans to be regulated like all other medical plans in California. I'm not going to provide some of the examples of where the lack of an independent medical review led to the jeopardy of a patient. I think some of the witnesses in support will make reference to that. But, Mr. Chair, with your permission, I'd like to present witnesses in support. Thank you.
Witnesses in support, please.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty. We hope to do 3 witnesses, 2 minutes each, please, with your indulgence. Western Center is a statewide organization, but when we have local programs that call us from Orange County, from Contra Costa, which are COES plans, and they have had problems with their plan denying care, we can't tell them they can call the HMO Help Center. We can't tell them they have an independent medical review. If they're in Los Angeles County and they're in LA Care, if they're in Contra Costa County with the Contra Costa Health Plan, we can refer them to the Department of Managed Healthcare. The Department of Managed Healthcare has a suite of consumer protections, everything from calling the HMO Help Center to resolve a problem, and if that doesn't work, you can go to independent medical review for medical necessity concerns, or you can go to external review for coverage disputes. DMHC enforces the outcome of these processes and use appeals as a gauge of issues that they should check into. So we think it important and fair that all Medi-Cal members have access to the same consumer protections and the same dispute resolution procedures. It shouldn't be a matter of what county you're in. Similarly, we think it important for all Medi-Cal plans to be licensed by California's HMO regulator to check for network adequacy, complaint procedures, timely access to care standards, and financial solvency. While the codes have raised concerns about duplication in having a contract with the Department of Health Care Services and a license with the Department of Managed Health Care, that's the case for every other Medi-Cal health plan, the commercial plans and the local initiatives in many of your districts. The departments get plan filings from one another. They do joint audits, and they're doing a lot to try to maximize efficiency, but they do play different roles, and we think they both have an important role to play. We ask for your support for standard protections for all Medi-Cal members. Thank you.
Good afternoon, Mr. Chair and members. My name is Liza Thanchanon. I'm the Managing Attorney of the Health Rights Unit at Legal Services of Northern California. We provide direct legal assistance to health consumers in 32 counties, 14 of which have county organized health system plans. In our remaining 18 counties, all have Medi-Cal managed care plans, which are Knox-Keene licensed and are regulated by the Department of Managed Health Care. Since we serve counties that have COS plans and non-COS plans, we see the stark difference in the results that happen from the consumer protections and oversight that DMHC can provide. One of the biggest differences is the timeliness with which a Medi-Cal consumer can appeal a health plan's decision. In Knox-Keene licensed plan, if a consumer is denied a medication or a surgery, they can request an appeal through DMHC, which can usually be resolved within 30 days or 3 days for an urgent appeal. Consumers in COS counties, however, only have access to appeal a denial through the state fair hearings process, which takes a minimum of 3 months. For example, we recently helped a 3-year-old boy from Ocoee County with a gastrointestinal disorder. He urgently needed surgery. Because of his urgent condition, we requested an expedited state fair hearing, and that took 3 weeks to get. In the eyes of a consumer who's waiting for health care, the difference between 3 days and 3 weeks can feel like an eternity. COS consumers also do not have access to the independent medical review process in which an independent doctor reviews a health plan denial and determines medical necessity. Again, COS consumers only have access to the state fair hearings process in which an administrative law judge with no medical training has to review medical journals, medical studies, lab tests, and determine medical necessity. For example, I had a client from Ocoee County who was denied a medication because the health plan said it was not medically necessary. At the state fair hearing, the consumer's doctor and the health plan's medical director presented opposing medical opinions as to the medical necessity of the medication. The administrative law judge, not sure about the medical literature that we presented and not sure which doctor to go with, he ultimately stayed the hearing and asked the consumer to see a third specialist as a tiebreaker, and that whole process with the hearing and seeing a third specialist took 6 months. So I'd ask that you provide protections to the same protections that all Medi-Cal managed care members have to Coast County consumers. Thank you.
Witnesses in support.
Hi, my name is Kristen Jacobson. Honorable Chair Bonta and committee members, thank you for allowing me to testify. I am here today representing Autism Deserves Equal Coverage Foundation, a nonprofit supporting families with autism spectrum and related disorders. I am here particularly to share the story of one girl whose tragic situation reflects the plight of thousands of beneficiaries of COS plans who do not have the critical protections of independent medical review and continuity of care, which SB 260 would make available to them. Megan is a 15-year-old girl who's a beneficiary of the Alliance for Health of Santa Cruz County, a COS plan in Senator Monning's district. Megan has severe mental health needs and extreme behaviors, making it impossible for her family to keep her and themselves safe without crisis intervention services. Between December of 2014 and May of 2014, Megan was sent to the Crisis Center for a 5150 evaluation, which is an involuntary psych hold due to immediate risk to self or others. 7 times. And during that time, she's been violent with her family several days a week and expressed many suicidal feelings, including wanting to be put to sleep like a sick dog. In the interim, her health plan was unable or unwilling to provide any services. I was introduced to her a couple of months ago and worked judiciously filing appeals with the health plan, filing appeals with county mental health, and retaining the services of Legal Services of Northern California. But because we didn't have an independent medical review, there was no resolution for Megan. And 6 weeks later, she requested an expedited hearing. 6 weeks later, she had still not even gotten a hearing date. She's suicidal and risk of hurting her family. She had to be removed from the crisis center in an ambulance, restrained because she was attacking her family and staff, and yet she was unable to get an independent medical review, which the DMHC would have been able to get resolution within 72 hours. This tragic situation can be avoided, and I sincerely urge the committee to allow Megan and the other 2 million consumers in CO's plans to have access to these critical protections. Thank you.
Thank you. Additional witnesses in support, please.
Tam Ma with Health Access and strong support.
Eduardo Martinez with the California Medical Association. Network adequacy and timely access, very important. Please support.
Thank you. Melissa Cortez Roth on behalf of Autism Speaks and the Center for Autism and Related Disorders in support.
Noé Paramo representing California Rural Legal Assistance Foundation in support.
Thank you. See no additional witnesses in support. Witnesses in opposition.
Thank you, Mr. Chair and members. Trent Smith representing various county organized health systems, including CalOptima, Partnership, and Gold Coast. I appreciate the Senator's kind words in his opening comments about the success of county organized health systems. I want to elaborate a little bit about the history and the success of the COES model for many of you who may not be familiar because you don't have a COES in your district. County organized health systems have been around as a model of care for approximately 30 years, many of them 20 or 30 years old. They've always been regulated by the Department of Health Care Services. They are the only entity providing care in their service area, so unlike some of the other models, they're not competing against a commercial plan. Some of their quality history. In June of 2015, the Department of Health Care Services released their aggregated quality score for Medi-Cal managed care plans. 7 of the top 10 performing counties were served by a county organized health system. There's been similar results since the department started that matrix of measurement. Since February of last year, county organized health systems have occupied 6 of the top 10 spots. In 2014, this past year, CalOptima of Orange County was ranked the #1 Medi-Cal plan in California by the National Committee for Quality Assurance, an independent national accreditation organization. Recently, Partnership Health Plan did a survey of its members, its enrollees. 91% responded that they were happy or very happy with the services they were receiving from Partnership Health Plan. With regards to grievances and complaints, last year there were approximately 2 million enrollees in county organized health systems. Combined, they had a 0.16% of enrollees filed a grievance with their health plan. So less than 0.25%. When you took into consideration all of the interactions, a doctor's visit, a pharmacy visit, clinic visit, it was less than 100% of those interactions led to a grievance or complaint. County organized health systems have a long history of providing services well beyond what is required by the state of California. Many of the codes provide vision services and eyeglasses, podiatry services, doctor recruitment bonuses for hard-to-serve rural areas with limited access, quality bonuses for providers who make sure that their enrollees are getting preventative care, and enhanced rates for skilled nursing facilities. These are just some of the services that the county organized health systems provide, not because they're required to by a state regulator, but because it's the right thing to do and they have the freedom and ability to do it. This is a case of robbing Peter to pay Paul. As you've heard, we are regulated by the Department of Health Care Services. We get all of our money from the Department of Health Care Services. Under this bill, we would have to pay the fees to the Department of Managed Health Care to get licensed. That's at minimum a $3 million price tag.
You're 30 seconds over time. Please try to wrap up.
Mr. Chair, the other witnesses had 3 witnesses. We have 2, if I could ask.
Each side has 6 minutes. They split it up 2 minutes apiece. So you can continue. You'll just have less time for your second witness. You're at 3:30 now.
Then I'll do my best with the time allotted. Good afternoon, everybody. My name is Bob Freeman. I'm the CEO of SenCal Health, and we are the county organized health system that serves Santa Barbara and San Luis Obispo counties. First of all, we want to convey our support and admiration for Senator Monning. He's a good representative for our area. However, on this particular measure, that we see it as a solution in search of a problem, we are very committed to the health and well-being of our membership. And we are also entrusted by you to use taxpayer money wisely and spend it efficiently. And as we look at this bill, we look at what's the added value we're trying to obtain here. Reading from this committee's analysis, it says that both DMHC and DHS have overlapping areas, including utilization management, access and availability of services, quality management, grievance and appeals, case management, coordination of care, access to emergency services and payment, and prescription drug benefit and authorization process. So those are currently would be duplicative under this measure, which the DHCS already recognizes. And the second quotation here from to take analysis is, the most notable difference in consumer protections is in regard to the IMR of disputed health care services or extended for external review. In our instance, if that is the crux, we've already expressed our desire to work to see if we can come to an agreement that would allow us to provide independent medical review outside of having the whole layer of regulation added to that. Speaking for my plan, we would have had about 10 cases that could qualify for IMR in the last 12 months, none of them what you would call serious or life-threatening. So, again, we want to be as efficient and effective we can be. We are all about our members. My own plan has a less than 2% denial rate. So we think it's the incremental addition of value here is not outweighed by, in our case, it would be about $250,000 in fees, which if you looked at the IMR as being the difference, that would be, at least in my math, $25,000 to access an IMR, and we think that money can be used in other areas that would be beneficial to members as well. Thank you for your time.
Thank you. Additional witnesses in opposition? Seeing none. Questions or comments from Assembly members? Assembly Member Ridley Thomas.
Yeah, a few. Mr. Smith, can you finish your comments very, very succinctly?
Yeah, the point I was going to make, Assemblyman, and appreciate the opportunity, is that we receive our money from the state of California. And right now, we are able to use the surplus money that we are able to accumulate on the services that I was providing, well and beyond what is required by the state. With this bill, we would be taking that extra money, at least $3 million in fee, from the Department of Health Care Services, paying it to the Department of Managed Health Care for a new regulatory scheme, which we think is duplicative of what we already encounter with the Department of Health Care Services. So you are just taking money from, again, one pocket of the state to another pocket of the state without what we believe to be a great benefit to our enrollees, and we would rather spend that money on direct patient care.
Okay, thank you. And, sir, I'm sorry, I didn't get your name or the name of your plan.
Oh, I'm sorry. Name again is Bob Freeman, and my plan is SenCal Health in Santa Barbara and San Luis Obispo counties.
Okay. Oh, SenCal. We have one of the listed oppositions. Senator, at least one of the plans in your area is opposed. I'm concerned there's some things raised in the analysis. I see that we have amendments here that delay implementation a year. The telephone center, what is it called? The managed care help desk, maybe is the name of it, has a significant backlog. I first learned about it during I don't know if it was 2013 or early 2014 during open enrollment, and these telephone lines and others were flooded. And my district office was taking calls to try to help triage people or be an ombudsman. And there were other changes in the healthcare system, and there were more people that were getting into the healthcare system to comply with the Affordable Care Act.
If I could just comment on that point.
Okay, yes.
Because I think you're right with respect to the Medi-Cal health line. I don't know if you're speaking of the DMHC maintains a health line that I believe is more efficacious, and that would be one of the benefits of this bill should it become law.
Oh, as opposed to are you saying that it's in fact the opposite, that the current healthcare services hotline is the delayed and the DMHC is more efficient? Is that what the understanding is?
Assembly member, no, the analysis refers to the DHCS Medi-Cal Managed Care Ombudsman, which, as a recent audit showed, has thousands of unreturned calls. But the HMO Help Center, to which this bill would give consumers in Coos County access, does not have a backlog. So this bill would would directly address that point, sir. So,
I'm sorry, I may have misread the analysis. And there may be a point there because it has I think they mean February 2014 and January 2015, which is what they're talking about with the audit. So you are suggesting that this bill will help people who have various issues with their plans, if it's a co or a commercial Medi-Cal plan, either of them will be able to access help more quickly.
Correct. This bill goes only to the county organized health plans. We do believe it would provide better patient-consumer access to those health lines. And I would also comment that some of the opposition concern about cost or shifting money that's state money that they're currently using and then having to use it for the application, initiation, licensure under the DMHC Knox-Keene, those fees are reimbursable, and the federal government reimburses half of that. So it's in the long run, it's not taking money from patient care. We've agreed to amendments that would extend the period of time to pursue that licensure. Most of the COES plans, it would be what's called a modification of their existing licensure. Okay. There's one plan we know that would be a de novo licensure, and we've extended with the amendments.
Is that a term of art, or is that what is de novo? I'm sorry.
That means new. A new.
Oh, new. Okay, got it.
They would have to start from scratch.
Got it.
The amendments that we've accepted would give them 18 months to pursue that procedure.
Is that Gold Coast?
That's correct.
Okay. If Coles were in L.A. County and this proposal was before me, I would frown upon the proposal. I'm not sure that this is
but if I could point out, L.A. Cares does benefit from these patient protections. That's who many of your constituents have the benefit of. Many of my constituents don't.
But from what I think I hear about Coles, I'll phrase it this way. If it were a local plan that were organized under this system, I don't know that I would be advocating for this proposal, particularly if it affected my constituents in changing. You have two plans that you say you think do decently, but there are concerns with the review process and maybe the independent medical review you think is more helpful than the administrative law process. I don't have as many challenges with the administrative law process, frankly. They are professionals who are there. They review a wide number of cases. They have specialties in various industries.
They're not medical professionals.
Well, many of them have, all of them have legal training, and then many of them are clustered, as you probably know, because they deal with these cases. I mean, there's several that live in my district who this is their full-time job.
I know a lot of ALJs as well, but the difference, if I could, the difference between independent medical review, you have medical professionals conducting the review. The problem under the COES review system, it's lengthy. You have life and death issues when they do arise that don't lend themselves to a 72-hour adjudication, 3 weeks, 6 weeks, 8 weeks, and then you get before a hearing officer who's not a medical professional. So as the witness pointed out from the Northern California Legal Services, even when they got the medical experts in there who had differing opinions. The ALJ didn't feel qualified to render a decision and sought a further review by another third party. For a family whose child's health is at risk, maybe their life is at risk, they don't want to be told that the ALJ has good legal training and can turf it to medical professionals if that's called for. Under the independent medical review, they're going to get a medical review immediately, and it's going to be independent. It's not going to be the medical review of the plan who, for whatever reason, has said you don't qualify for us to cover your child's crisis. We need to tighten that up. It's what every other Medi-Cal delivery system in the state is playing by those rules. These codes started as small plans, and they've grown. They've grown to be larger. And again, they're doing tremendous work on the ground. Quite honestly, I'm surprised that there's resistance to wanting to conform with better protections for patients, especially if the services are so good and the complaints are so few.
Thank you, Senator. Point well taken. The last thing that I'll say, and I know that others may have other points. It seems to me the kind of tack that I was going down about if I had a coast in my area and it looked like, I don't know if it's $3 million aggregate or $3 million in one of the plans that was not going to go back to whatever was in that system, even if we got the higher reimbursement from the feds, which you say if we go into Knox King you get reimbursement on half, and I don't know if the general fund has to pick up the remaining half or some other pot of resources, that it seems like a loss of resources for the delivery of services in that area. So a plan can, I guess now, if those are discretionary resources, invest in any number of initiatives that they feel are important to increase health and wellness in their particular area. It seems like, it appears as though I hear there will be less. That is of concern to me.
Right, and I share that concern. My read would be, I think we've addressed it partially with the amendment of giving them more time to perfect that application and advance the fees that would be necessary that are reimbursable. So we're looking at plans that are dealing with tens of millions, hundreds of millions of dollars a year, and we're not in the long run taking that money from them. They're going to get reimbursed for those fees, and their patients are going to have access to the call health line, to independent medical review, and to playing by the same rules that others that we regulate who provide Medi-Cal services are being held to.
Thank you, Senator. Thank you, Mr. Chairman.
Thank you, Assemblymember Bonilla.
Thank you. I'm in a unique position where I have one of my counties that's already managed or regulated by DMHC, and then another county have a plan that isn't currently there. It seems to me that the biggest issue is around cost or the use of funds. But as you just were mentioning, and perhaps I could just get a little more clarification, I want to hear from the opposition. If at the end of the day, at some point in time, I don't know if you can tell us how long it will be that the cost would be recouped, would it be a year or two, and built into the Medi-Cal plan rate. If we can resolve this issue of cost, I'm wondering why there's still opposition, and is that an incorrect understanding that I have, that the cost truly would be eventually kind of a wash?
Yeah, I don't think there's any dispute about the fact that the cost would be reimbursable, Assemblywoman. So I think there is a time lag, but certainly the health plan fees that the plans would pay for the Department of Managed Healthcare are reimbursable as part of the Medi-Cal plan rate.
So I'd love to hear from the opposition why. I understand if there's a lag, but at the end of the day, aren't you going to come out whole?
Well, I think the best way to look at it is this is correct that they'll be built into our rates, but that just means the state is paying for something twice in our view. Like I said, there's a lot of overlap on here. And then the only part that I can see that's really not overlapped, the most notable would be the IMR process. So for these other things, regulating for access to care, coordination of care, quality of care, et cetera, that's being done twice now. And our view is we're entrusted to manage funds appropriately and efficiently. and effectively. So we just have the philosophical question of why do we want to pay for something twice? If the issue is the ALJ versus IMR, and I will
You're
speak
using
from,
a lot of acronyms.
Oh, I'm sorry. I'm sorry. Let me
you're
back up.
losing us. Yeah.
If the issue is the administrative law judge versus independent medical review, I can't speak to the example given, but our direct experiences from our plan is that administrative law judges, if there is a clinical issue, they, in our experience, almost always line with the member because they don't want to be making clinical decisions. So we're not thinking that there are always going to be tough questions, but we just see that we're being asked to do something twice, and you can say 3 times if you add the federal government regulation of Medicaid, which is trickles down to us as well. So that is, we don't mind being regulated. We just want to be effectively or efficiently regulated.
Through the chair, if I could follow up. Could I ask you to respond to that, the idea that we're paying twice for these services?
Thank you, Assemblywoman. I think our view is that DMHC and the Department of Healthcare Services through Medi-Cal and the Department of Managed Healthcare play very different roles. So it is true that all Medi-Cal plans have a contract with the Medi-Cal plans to provide Medi-Cal services. But the Knox-Keene Act, many provisions of which, including the independent medical review, were passed in the late 90s, well after the formation of the COES. There are a number of important protections. The Department of Managed Healthcare has a different role. They license, they regulate, they're checking for timely access to care. They do track complaints, they do audits, they do corrective action sometimes. So we know that DHCS is the Medi-Cal purchaser, but the Department of Managed Healthcare is the HMO regulator that's well served, we think, to review the adequacy of the plan services being provided and make sure that the consumer protections are in place.
So you're drawing a distinction between the purchaser versus a regulator, and what we'd be considering today would be bringing in the layer of regulation that currently isn't there.
Yes, ma'am.
And I would just beg to disagree in the sense of I always think DHCS will always be a regulator because they're a single state Medicaid agency entrusted with enforcing federal regulations. So that they're not just a purchaser.
I mean, to me, it's, I don't have a really strong opinion either way, but I feel, and because I have these two different experiences that are running fine right now, I don't have a really strong opinion, but I appreciate this distinction, and I think that sometimes there is a benefit to statewide consistency and uniformity, but I will be interested to hear if there's any other discussion from members and see what I decide. Thank you.
Dr. Wood, then Assemblymember Burke.
Yes, thank you. And I met with the author yesterday. We had some discussions, and I will tell you, I'm a bit conflicted. Partnership Health is the plan that administers in every county that I represent, and it's very rare that I hear that I have heard in the past of a managed health care plan for Medi-Cal that actually works really, really well, and it does. So I am conflicted when I hear from them that this will incur additional cost to them, and beyond. Granted, now I'm understanding that some of that will be reimbursable, but I also get. Now I'm wondering if are we ultimately paying for something twice or not? I've also heard the answer to that. So I know that in the past, from what I've heard as well, DHCS and DMHC have had conflicting policy decisions, which can create problems for plans as well, which could delay care as well. The one thing that's brought up in the discussion that I'd like to put out is that we have heard that the independent medical review, that the plans are willing to institute that on their own, which I think would take care of part of the reason for the bill. So I'm curious if plans were truly willing to do that. What is the benefit beyond that? Because I'm really a call line or an ombudsman. I'm not really sure that really helps if you get the review that you're looking for. So that's my question.
Right. Well, it's a fair question. We've had some of these conversations with the opposition. So I think the fundamental difference between the status quo within the COES and that appeal system to administrative law judge and the establishment of an independent medical review is that word independent. So it would be a little bit contraindicated if the plan's offered to establish their own independent medical review, because then it's the plan that's still setting it up. And so for the patient or the patient advocate, if that system of independent medical review is under the umbrella of the COES, it lacks independence. So perhaps that could be addressed by setting up a system of total autonomy outside the COES. But if you're going through the COES to exercise that, you lose some of the autonomy and independence. And maybe you have something to add?
Yeah, I think we would just add to that, Assembly Member, that we don't think IMR is a standalone piece, that it is important to be able to call the HMO Help Center just to know that you have the right to the independent medical review. There also has to be a decision made as to whether coverage, whether a care denial is a medical issue or whether it's a coverage issue, and only medical issues go to independent medical review. So the Department of Managed Healthcare makes that initial decision about whether you're even eligible for IMR, and then after the fact they enforce it and they track it. So we think those are all important pieces, the before and the after, not just the standalone.
And they have multilingual capacity.
Yes.